To join y'all from sunny Columbus, Ohio. Currently 65 degrees, 2 to 4 inches of snow expected by tomorrow morning. So welcome to Ohio. I'm here at Nationwide Children's Hospital in Columbus. I also have a faculty appointment at The Ohio State University, as well as with our ACO, Partners for Kids. So I wear a lot of different hats within our organization, and I wanted to share a little bit about some of the work that we're doing here within those organizations to kind of share across the board. As Petty mentioned, I'm part of CFHA. CFHA has really felt like home for me as a person with interest in integrated primary care and collaborating with people across different professions. I think a lot of our professions can be a little bit siloed in our professional organizations. I think that's a safe place to kind of think through and problem solve what we're doing as a profession, but I think some of the work that we're doing across integration requires reaching across the aisle and talking to other people, and CFHA has been a really nice way to be able to do that. So I threw together some slides. I could talk integration literally all day, every day. My wife's like, please, can you not talk about integration with this dinner tonight? Because can we just give it a rest? And so I'm happy to talk as much as you guys are willing to tolerate. I have some slides to throw together. Please stop me and interrupt me though. I'm gonna try to leave some time at the end to discuss as well, but I have a ton of slides. So feel free to stop me as I'm going if you have questions. All right. Getting the slides pulled up. So talking about different ways of doing this, I would definitely want to give a shout out to my partner, Ujwal Ramtekar. He's a psychiatrist, a child psychiatrist that works with me at PFK. He and I tag team. He's my partner in crime for a lot of this stuff. And when we think about some of our integration efforts, we like to think about it across SAMHSA's levels of integration, from coordinated, co-located to integrated. And when we kind of break down our programming across those areas, BH Tips is like a psychiatric consultation line that we'll talk about more on the coordinated side of things. We do Project Echo, if you're familiar with that, with regional pediatricians who belong to our ACO. We try to get them involved and get them going, learning their skills, learning ways of increasing knowledge about non-pharmacological as well as pharmacological tools to help manage some of those kids within their medical home, kind of take the burden off some of the specialty mental health services. We also have a behavioral health integration initiative that we'll share with you. And then here at Nationwide Children's Hospital, we also have a primary care network that's within our academic health institution. And so I'll talk to you guys a little bit about some of the integration work we're doing there. And we're fortunate to be part of a massive behavioral health system within our hospital setting. And so that allows us to be highly, highly integrated within our model. And so I'll talk a little bit about how that model is different. So these first three initiatives are the initiatives that are part of this community hospital and ACO partnership. And then the Nationwide Children's Hospital thing is kind of our internal work, our internal integration work. So BH Tips, that's our consultation program. It's really to provide some support to PCPs, improve the quality of care kids are getting out in the community. We really access a lot of the rural parts of the state through this program, through this and through ECHO, and really to help mitigate some of those challenges to access. Like everybody else, we do have long wait lists for our specialty services. And the more that we can do to help PCPs feel comfortable managing some of these things within their medical home, the more that they can take care of those kids, the more that we can reduce wait times and improve access, the better. So how this works is community pediatricians can just log into our scheduling system. They sign up for a 15-minute video consultation appointment with one of our psychiatrists and or care navigator. And then they talk about ways to link them to community resources, medication management questions. They kind of get a nice summary of the recommendations at the end to kind of summarize where to go next with that patient. And they can come back as often as they need to those appointments. As far as Project Echo, I feel like you can't talk about Project Echo without making the Brady Bunch joke, right? Like all of us on the screen there and all the little boxes. But we have multiple different parts of Project Echo at this point. So one of the things that we do is a foundational echo. So each week we tackle a new topic. We'll tackle ADHD, then mood, then anxiety, then trauma, eating disorders, gender identity. We have a different topic of the week, and we just provide one session topic on each, kind of cover the wide range of things. And then we have specialty echoes after they've been through the foundational echo. So once they've gone through that foundational one, if they want to take a deep dive on ADHD or trauma or depression, we have a multi-session echo that's dedicated specifically to that condition. Works kind of on this hub and spoke model. This is our hub team. So we have a pharmacist on our team. We have a social worker. We have me as the psychologist, and we have Ujwal Ramtekar as our psychiatrist. We have a family a family advocate on our group as well, who has a child with autism, who shares a lot of her experiences navigating the system and providing the family perspective to the recommendations that we provide, as well as tons of people running tech support and procedure and operational support behind the scenes as well to make sure that that all flows smoothly. So we're fortunate to have a pretty good team here. If you don't know about Project Echo, just real quickly, the thing I love about Project Echo is that we can then provide this multidisciplinary consultation to the PCPs and take just a few providers and contact a very large group of patients by doing that. But we also learn lots from the providers in the community too. We learn a lot about how they're disseminating best practices, where their comforters, where the gaps and resources are in the community. We learn tons from the spokes in this model as well. And we also learn from each other, us hub team members. We're always kind of learning new things and new tips. I'm picking up new metaphors to use with families along the way. Project Echo works the way that we run it is we start by a quick 10-15 minute presentation didactic on the topic of the day. And then we have the participants, the spokes, bring in a case, and then we facilitate a conversation about the case. So rather than just answer their questions, we have the other PCPs within the Echo actually say, like, what clarifying questions do you have for this case? What additional information would you need to know? And then the hub team, the experts, then will ask the same questions. And then the spokes will provide recommendations, and then we'll wrap it up as the hub team and summarize the recommendations, make sure that they're linked to the best evidence that we have, and then summarize them and send them out to the people after the Echo. So the whole team learns from the case. It's really great because BH Tips is great, but we're helping one PCP at a time through BH Tips. Project Echo is great because we can have 20 regional PCPs in our office, and all 20 of them get to learn from the case that's presented that day. All 20 of them get to learn from the didactic that's happening that day. So it's a really nice opportunity to really reach a large number of pediatricians, provide consultation, and affect a really large number of patients within just an hour a week for our Project Echo. This is kind of the reach that we've had so far in Ohio. So this is all 88 counties in Ohio. We've reached 41 of them. We've touched 101 unique organizations, community primary care organizations within our state. We've actually had some people from like Dublin, Ireland and Texas jump in. I don't know how they're finding out about this, but we definitely have them if they do the work to find out about our Echo that's dedicated for Ohio, we're like, sure, come on in. If you've done that much work, you can participate. We've hit 75 primary care providers and had 9 total cohorts at this point. We published an initial paper of our initial outcomes. The providers who have gone through this feel like they've really made some significant gains, particularly in knowing how to prescribe medications, make correct diagnoses, evidence-based interventions that are both pharmacological and non-pharmacological. And one of the great things is just how to talk to families about mental health concerns. So many of the times they come back to us and just say, just having a metaphor for how to talk about anxiety or depression with a family, or having some basic tips that I can provide them, has been really powerful for us. And one of the things that we were particularly happy to see is that we actually showed a reduction in the use of polypharmacy in the providers who attended our Echo. So it wasn't a massive increase, but fortunately there wasn't a massive decrease, but fortunately there wasn't a lot of polypharmacy happening in the first place, but we did see a significant reduction after they participated in our Project Echo, which we were really happy to see. So moving on to more of our co-located, we partner with local pediatric offices that are part of our pediatric ACO. And what we do is we help partner them with community agencies, community behavioral health agencies, to put a behavioral health provider within their actual practice. Some other times we just actually help them hire a person just for their own practice or who are employed by them too. So we do some matchmaking, we do some staffing and hiring support. And how it works is kind of like the collaborative care model. So it's me and a psychiatrist. The program manager is me in this situation. Ujwal serves as the psychiatrist in this situation. And so what we do is we get a behavioral health consultant within the practice. We train them up. We teach them all they need to know about how to run behavioral health within primary care. And then we've created a pediatric focused registry because unfortunately there just isn't much out there for kids in the form of registries. I mean, kids, they need different forms depending on the age. There's a myriad of conditions that we focus on. And so we just created our own through REDCap. And we have a ClickView program that allows us to use that data in a helpful way. to be able to present it, sort it, run reports, those kind of things. And so what happens is the BHC sees the kids, puts them in the registry, and then monthly we have meetings with them. And so through the use of the registry and through monthly consultation with the BHC and the PCP, we're able to affect a lot of the families in the community as well. So it's kind of clinical assistance, training assistance, operational and technical support for integration as well, for folks in the community. I have a much busier slide here that shows all of the different roles within our program. If you're familiar with collaborative care, a lot of this stuff is going to be really familiar to you. And then we also have a couple citations here about the developments and of our registry as well, kind of how it functions, the things that we include, the things that we measure. The fact that we include both operational and clinical outcomes is really important to us. It really helps us provide some of that technical assistance as things are up and running. So those are two citations. I'm happy to talk about them a little bit more too at the end if we have time. So this is the monthly case reviews. We go over the registry first. We pull up all the people entered in the registry. There's a place for them to flag whether they want us to consult with them about that particular case. But we also go through and comb through the whole registry anyway to find those kids that are kind of just stale. They're not really making progress. Make sure we bring them up and discuss them. Celebrate the successes that they're having as well, because it's really important when these practices are getting off the ground to really talk about how beneficial it was that they were seeing the BHC together with the PCP and the benefits that we're seeing from that. And we also provide pharmacological, non-pharmacological case support as well during those monthly case reviews. And then our internal model, this is really kind of my baby, what I was hired here originally to do before I start putting all these other hats on. We kind of have this multi-stepped model that we use. So we do a lot of support to our pediatric network, identifying primary care behavioral health workflows. So we're doing a lot of work right now on screening for depression, what we do when they screen positive, how PCPs are following up, training them and doing behavioral activation after they screen positive, following up with them until they're linked with behavioral health services if they need to, managing suicide workflows and implementing zero suicide within our network, doing a lot of trainings from everybody from our nurses to our front office staff, to our PCPs on how to address behavioral health issues. For example, we had a kid come in with autism that just absolutely destroyed the clinic because they were so anxious about the shot. So the nurses came to me and said, hey, what can we do differently to help these kids who are struggling with these visits? We met together as a whole team. We problem solved. I created this little Jungle Explorer passport, which is like a behavior plan for the medical visit. They earn their tiger stripes as they go through the visit for, staying calm, being brave, getting their vitals done, getting their weight done, getting the blood pressure cuff, all that stuff. It has games for the parents to play with the kids while they're waiting to keep them busy and entertained. So we kind of developed this clinic-wide intervention to help those kids. Implementing universal screening, do lots of those curbside consults as well, just pulling us aside and saying, hey, you don't need to see this kid. Can I just run my plan by you? We also do joint appointments. So these are warm handoffs, but they're also intentional follow-ups. For example, our kids who can't access behavioral health treatment elsewhere, but they are being managed with psychotropic medications. Maybe they're coming in monthly for med checks for ADHD or their SSRI. What we do is we do joint follow-ups, plan joint follow-ups during those visits. So they get both a med check and behavioral consultation within the same exact visit. They don't need to come in twice for two separate visits. We're able to jointly manage them. We're able to coordinate both of our treatment plans together. We just sit together, me, a pharmacist, and the PCP, the family, sometimes the social worker, whoever needs to be involved in the family, sit down together and make the treatment plan together, which is a really nice way of doing things. Also, for those kids that screen positive, we meet them pretty quickly in those visits. And then the psychologists, we do about 3 to 5 sessions on our own schedule for follow-up. We realized, though, that there's these kids who didn't need specialty behavioral health services, but were a little bit more than what we could offer them in 3 to 5 sessions. So what we did is we actually brought on some master's level co-located therapists within our model too. So if they just need a couple sessions, they'll see us as a psychiatrist. If they need to go through a whole manualized intervention, like a CBT intervention that's 12 to 14 sessions, we'll set them up with our co-located therapist who might run through an entire coping cat manual or an entire Barkley program with them to get behavior management skills under control. And then if they're not making progress with us, or if the needs are just really acute from the begin with, that's when we send them off to specialty behavioral health. This is just another way to look at our model. The thing that I like to emphasize in this is that much of the work that we're doing as psychologists within our model, within our internal model, is really providing support to mental or to primary care, really helping primary care take better care of their patients through consultation and support. Also helping our specialty behavioral health system. Our specialty behavioral health system is massive. We have literally, we're in over 20 of the schools. We have multiple specialty programs. We have close to home centers scattered throughout the whole city. So we really want to make sure that we're sending them to the right program. We're problem solving barriers. We're making sure that they maintain access to that care, sometimes stopping in, even though they're connected with a specialty behavioral health provider, to just problem solve what's going on. You know, they might be in the middle of PCIT and like, I know how to play with my kid. This is stupid. I don't want to do this anymore. And then we come in and tell them like, you are so close to dropping the hammer, right? Like you're about to hit the punishment phase. You cannot stop now. You're almost there. Just hang in there for a couple more sessions. This is why we do it in this order. This is why you got to stay with your therapist, or even problem solving, because maybe they're not getting evidence-based treatment. So how can they negotiate that with their current therapist, or maybe move through and get a new therapist set up with a new clinic? So we do a lot of that support too, in addition to that brief intervention with the family and that school consultation as well. These are our clinics. We're up to 7 psychologists and 7 clinics. We got 2 more coming. We have a psychology intern half a day twice per month. We have 2 postdoctoral fellows and 2 co-located therapists. We actually just hired 3 more, so we're up to 5. We're really excited about expanding that level of our work. That's been really meaningful for our work. So as I mentioned, we're highly integrated. So about 70% of the patient contacts that we have as psychologists are on the medical provider schedule, not on our schedule. About 30% of those are follow-ups on our own schedule. We see whatever walks through the door, birth to 21. I never thought I'd be helping moms stop breastfeeding when they want to, but it's actually something that comes up quite a bit in clinic. And it's really great, right? Because if you can't set that limit, what's it going to look like when they want juice later? Or what's that going to look like when, you know, they have a hard time separating at school at kindergarten? So we can really lay that foundation really, really early. Sleep training at 6 months old, really starting to talk about those developmental processes, attachment, behavioral principles, things like differential attention and setting limits. It's been really great to see whatever walks through the door. Keeps the day exciting for sure. We see about 5 to 10% of all primary care visits of all kids who walk through our primary care doors. We see 5 to 10% of them, regardless of age, regardless of reason, whether it's a shot only visit or a newborn first appointment with us. We see about 5 to 10%, depending on the clinic, of the kids that walk through the door. We're seeing many, many more kids every single year. Our model's really been developing and flourishing. It's been great to see us kind of double the amount of patients that we're seeing. COVID really wrecked us a little bit and the integrated side of things. So this is our proxy for our level of integration. We have data dashboards that we get every single month to kind of monitor some of these metrics. As you can see, we jumped up to about 75–80% of the appointments occurring on our schedule during COVID. But still, we were still able to jump in into telehealth appointments or call into the room and do some curbside consults and some warm handoffs virtually as well. We got that up and running pretty quick. I can talk more about that if people are interested about what that looked like, but we tend to run at about, we've spent about 2 years at that 70% on our schedule, or 70% on the primary care provider schedule, 30% on our schedule. That seems to be kind of the magic ratio for our system. And that ratio is different at every system. You kind of got to figure out what your system needs. But for us, that 70 to 30 feels really good for us. This is my favorite slide. At first, I'm going to present it and you're going to be like, well, of course. But then there's a little bit of a punchline here at the end. So when we look at before integration versus after integration, this is the number of kids who show up in primary care who have contact with a behavioral health provider within 180 days of that primary care appointment. So any kid for any reason, any age, if they stepped foot in our primary care office, what percentage of them had contact with a behavioral health provider within 180 days? So after we integrated, it jumped quite a bit. So patients in our integrated primary care clinics are about 134% more likely to be seen by a behavioral health provider within 180 days of their primary care appointment. All well and good, right? You're probably thinking, of course, you put a provider in a clinic, they're going to see more kids. I think what's amazing to me about this is we increased our clinical FTEs through our specialty behavioral health services by 65.5. So 65.5 FTEs increased in therapists and psychologists within our network resulted in 0.5% increase in access to care for primary care patients. So again, 65.5 FTEs hired by our specialty behavioral health services resulted in a 0.5% increase in access. Putting 4 FTEs within the primary care offices resulted in doubling the access for those kids. So like the return on investment for that was remarkable. 65.5, 0.5%, 4, 6%, right? Well, 6.1%, but it was just remarkable to us how much of a difference that made in access for our pediatric patients. 93% of the kids that we see them the day they present to the primary care office with a concern. For the 7% of kids who we don't see same day, maybe we're talking to a group in Arkansas or presenting at a conference or on vacation, we do get that referral if there's no reason to bring them back in the PCP schedule. It's, a 3-year-old for tantrums. The PCP is like, I can't justify seeing this kid again. Can you please just check in with them and give them some strategies? They'll follow up on our schedule. They usually see us within about 15 days from their primary care appointment. Our specialty behavioral health services occur in about 67 days. We have a metric here at the hospital. We try to get people in within 30 days of referral across all subspecialties. So we're seeing in our integrated settings about 91% of those kids within 30 days. It's about 36% for our specialty services. And we love our specialty services. We can't run our model without them. So this is not throwing shade on them. You should be able to see your primary care provider faster than you can see a cardiologist, right? Like that's just how healthcare works. And so we see ourselves as a primary care level of behavioral health support. They should be seeing us within a week or two and not having to wait months. It makes sense that we have that quicker access. We just want to make sure we're following through on that progress with this data or with that promise on this data. We've also shown a significant reduction in referrals to specialty behavioral health. We're taking significantly more care of these kids within their medical home without having to increase that burden to specialty mental health services. This is true for both therapy and for psychiatry. We've shown a reduction in referrals to both psychiatry and behavioral health, specialty behavioral health referrals. We're taking care of these kids in their medical home, where they feel comfortable, where they need. And then if they don't make progress with us, then we're sending them on to the specialists. Our providers are super happy. They feel like they're more efficient. They feel like the mental health care is more coordinated, that they get their questions answered when they have them. They actually feel like they're developing their own new skills and they're feeling more confident. I love it because sometimes the medical residents or the attendings will come to me and say, hey, I know all about those bedtime passes now. This kid's getting out of bed all the time. Can you hand me some of those bedtime passes? I'm going to give them to the kid and work through it. So it's like really great to see them show their new skills. And then this is my last slide. We're actually seeing a significantly higher number of those kids that are birth to 2. So about 23% of the kids that we see are in the birth to 2 range, whereas specialty behavioral health is only about 12%. And almost all of those are for developmental and autism assessments. That's not necessarily for treatment. So we're really doing a lot more prevention work with those kids. We're actually reaching a much higher percentage of the Latino population within our clinics, which is really great to see. The percentage of the population we're treating looks a lot more like the percentage of the population or what the population characteristics look like of the clinics in the first place. We're also slightly more likely to see self-pay or uninsured folks versus commercial insurance when we compare who we're seeing within our integrated clinics compared to specialty behavioral health. All right, I talked so fast and I blew through all of this because I didn't know which of these things was going to be more of interest to you. So that's kind of the whole smorgasbord of all the stuff that we were doing. And I'm happy to talk in more detail about any specific things.
That is exciting, Cody. It's nice to see the whole gamut and continuum of what you have. One question I have is that you said that you hired 64 more FTEs in the specialty mental health clinic, and yet you only hired 4 FTE in primary care, and yet you had that huge difference in the number of patients that were seen. So the location of the mental health provider really seems to make a difference. Is that?
Absolutely. Yep. Yeah, it makes a huge difference seeing them in their medical home. And part of it is just like, you can't no-show appointment you're already at. Right. So we know in our system, 60% of the kids we refer get an appointment in the first place. And then 60% of them attend that appointment with specialty behavioral health. And usually that's months later when they've identified a new solution to the problem or different things. And so, our joke is that you can't no-show an appointment that you're already at. When you screen positive for depression, we're going to show up during that appointment and we're going to get you taken care of. And we're not just going to do assessment. We're not just going to schedule you to see us later. We're actually going to do behavioral activation and talk about the etiology of depression and what your treatment options are. We're going to follow up with you in 2 to 4 weeks within our primary care network to see us and the medical provider, which is huge because we treat a large refugee and immigrant population here. And not all of them feel comfortable seeing a psychologist, but they're willing to come back and see their PCP and allow me to consult during that. And so it's been really great to access some of those populations who we weren't reaching prior.
Fantastic. Thank you so much. That's pretty amazing. I know people have to go maybe, but I don't know what your time constraints are, Cody, but if you have a little flexibility, anybody have any questions? And if you need to go, please do. But this is a great presentation with raises many questions that I think that would be useful for our group.
Cody, do you get this data that you presented from claims data, knowing that they're going to the specialty services, knowing that they're seeing providers X days after a visit? Is that claims data that you're using to figure
So
that out?
we're primarily using data from our medical record system, which is Epic, and we're able to track referrals, appointments scheduled, reasons appointments weren't scheduled, and those kind of things. We're also incorporating some claims data for the kids who are referred outside of our network. So usually we refer within our own network because we're so well developed that we're taking care of a lot of these kids within our own system. But we did realize that there are some community behavioral health referrals that we're not capturing with that data. So we're working on getting some claims data to look at those things too.
Curious, did you have any barriers getting this started? And one of the things that we hear is sometimes difficulty with utilization and how do we utilize the BHC? And we see them, maybe they're not having the amount of visits that are needed, or maybe the BHC isn't really comfortable with a specific population. What specific barriers did you have in starting this program?
Yeah, my favorite story is that 3 of my providers walked out of the meeting where we introduced that we were coming into town. And now they're presenting at PAS with me talking about how that was a big mistake. So, it's great to see how that kind of transitioned over time. They were very worried about workflows. So, co-located therapy from a workflow perspective is pretty easy, right? I drop a referral, they see you in an office somewhere in the clinic, but we're doing 70% of our work on their schedule. And so they were very worried about time frames, people getting in and out, space, order, who goes into the rooms first, who doesn't. And so those were kind of our biggest barriers: space, time, workflows. Those are the things they were most concerned about. We were able to kind of partner with our nurses. We spent a lot of time shadowing to figure out where the gaps were, able to point out that patients are sitting in rooms and in lobbies for very long periods of time. They're getting HPV and waiting for 15 minutes while nobody's talking to them. I can do behavioral activation in 15 minutes. So why don't we at least, get that done? And so those were the big barriers at first. It was all preparatory anxiety, right? It's all these things that they imagined, all these disasters. And as soon as we were in clinic, they were like, oh my gosh, this is not nearly as bad as I thought it was. And even then, when I started filling some co-located appointments on my own schedule, they were like, can you stop doing that? Like, we need you available right now. I was like, no, you can interrupt me. It's fine. But they really bought into the integrated piece. We started with the integrated piece first. We did not, I always joke that the co-located piece is the dessert and the integrated piece is the vegetables. And we made them eat their vegetables before we offered the co-located stuff. And it really worked out great that way. They really were fearful but bought in once it happened. We did a lot of training around how to talk to families about us anyway. And so, there were definitely times where folks said, I don't want to see a psychologist. And so we said, well, how did you introduce me? And one doc's like jokingly, yeah, I told him we have a shrink down the street, so now we can just get him involved in visit. I was like, that's not going to be productive. Or let me bring in the psychologist. And it's like, why don't you just say we have a team member who's an expert in this and we'd like them to come in and introduce you. And then I come in and I introduce myself, and usually it's fine. Sometimes I have to promise them that I won't do any mental health work or psychology if I'm just allowed to go in and say hi. And then usually by the end of the visit, they're like, okay, doc, one question, help me figure this out. And then if you're helpful to them, then they come back. My favorite story is we had this family from a country in East Africa, and they were like, no, we are not going to talk to a psychologist. They allowed me to come in and say hi. And then for weeks, every time they were coming in to monitor some weight and some elevated obesity labs and had wanted nothing to do with me. But then there were some things that happened in the family, and they asked to see me at one point, and I was just going in to talk with them. I couldn't bill for anything. There were definitely points where I was like, why am I doing this? I'm not getting anywhere. But then something happened in the family, and they came in for a weight visit, and they're like, we don't want to talk about weight today. We just want to talk to Cody.
That's so awesome. Thank you.
Yep.
Very enjoyable presentation, Cody. Could you talk a bit about how you're reaching outside of the nationwide setting, like people who aren't part of your financial structure? How does that work?
Yeah, so the ACO and our community partners are super helpful with that. There's a bunch of landmines, as you can imagine, So like if we get a primary care practice to hire a behavioral health provider, but that comes from this behavioral health organization down the street who's struggling to recruit for themselves, obviously we're just causing more problems in that situation. So we do lots of strategic partnerships. Fortunately, we have an entire department within our hospital who's in charge of outreach, making relationships, building relationships with both the primary care practices and the healthcare systems and the behavioral health practices across the board. The other thing we do is we just do a lot of consultation. And so, we've been able to do this with enough practices that we're able to say, this practice really was successful in billing in this way and working with their payers this way. And this practice actually negotiated this with their practice. And we were able to kind of figure that out on a case-by-case basis. Our ACO, PFK, also has certain payment incentives for reaching certain HEDIS metrics or other metrics as well. And so we really partner with them to say, hey, we noticed that you're really hitting this metric, 1 month a year. Through our behavioral health integration, we could probably hit that metric every month with our eyes closed. In fact, the last 3 practices we did, we're able to hit that metric with their eyes closed every single month, which estimates about this much more revenue for your practice because you're able to hit some of those incentives, which has been really helpful. Helping them hit those markers for like patient-centered medical homes and accreditations through those kind of programs have been helpful too, to be able to walk them through what the guidelines require, how our program fits with that by having a psychiatric consultant, by having access to a behavioral health provider within their network as well. And so that's some of the ways that we kind of partner, we identify with them, we incentivize some of the work that they're doing. And some of those incentives exist, they're just not meeting them. And this is kind of a solution for them to be able to meet them more regularly.
Are they all part of the nationwide ACO?
The Partner for Kids ACO, yeah. So Partner for Kids is the ACO, but they're kind of related to our hospital too. And so it's kind of like our hospital, the ACO, and the community partners are all kind of working together during meetings to figure and align some of these strategies.
Thanks.
Yeah.
You're on mute, Alan.
Any other questions? Sorry. Great presentation. I really thank you for it. And I would guess that you would be available for talking further if we have other questions that come up in the meantime. Do you have an email that I know Patty has it, so I'll just ask her about it.
Yeah, she could definitely send it out and I'll type it in. It's just my first last name at nationwidechildren's.org, which is like, right? Can we have a longer email address? But I just typed it into the chat. But I mean, I ain't got anything to do, so I'm happy to answer more questions if people have them.
Well, everybody, I'll let you all go, and we'll look forward to, seeing where we can go from here. I have a good friend in Columbus who is he's an adult family practice guy, who's VP of not the nationwide, but the adult, I forgot the name of the organization of many hospitals. I'll ask him about you.
Yeah. Check up on my references. That'll be good.
There you go. But thank you so much. And I hope we have some further conversation. You certainly bring forth some good, to know what other people are doing is very helpful. Every context is different, but there's no question that we could take some lessons learned. Thank you.
Yeah, agreed. I feel like behavioral health integration is all beg, borrow, steal, right? We're all learning from one another and sharing materials and building it and problem solving together. So it's always good to know what other people are doing.
Anything else, Patty, that you have?
No, I was just going to say thanks, Cody. This is exactly what we were hoping to get, is some pictures of different things that are being done. And, this group is at the beginning of forming. So how to share some best practices, where to start, and to get to know some people that are doing some great work. So it was exciting.
Okay, well, I think we'll close there and look forward to the group meeting anytime it's necessary in between. I know everybody is busy, but if we don't talk to you before a month, we'll talk to you in a month. So have a good day, everybody.
Thanks.
Take care.
Bye-bye.
Everybody, thanks.